Good morning, everybody, and welcome to SPRA Radio. I'm BJ Sinclair, and today I'd like to ask our listeners a very interesting question. Should men over the age of 75 take a PSA test to find out if they have prostate cancer? Well, I don't know about you, but I've always heard that men should start having PSA tests by the time they reach their 60s, and maybe sooner. So why would testing be considered a bad thing? Joining us today is Rob Parker, a medical professional who's been experiencing prostate cancer firsthand for the last decade. Welcome to the show, Mr. Parker.
Thank you. Great to be here.
So before we get into the whole PSA testing dilemma, let's give our audience a little bit of background on prostate cancer itself.
Well, good question. Let's start with just what normal cells do. Normally, cells grow, divide, and then die. Cells like to have the ability to grow because they can repair tissue. They grow so that when you're a kid, you can grow bigger and taller. And then they divide, and then they die. So what happens with cancer is that cells will live forever. They lose the ability to die, and then they divide uncontrollably. Those dividing cells become tumors. Cancer is metastatic, which means that the cancer cells acquire two separate abilities. They can travel through the blood system or the lymph system, and they can invade other tissues. That ability to make tumors then creates problems because it crowds out normal cells in other organs. Those normal cells begin to die and the cancer takes over. The organ dies. If there's a system of organs that stops functioning, then the host or the person dies. Prostate cancer is basically that process, starting with cells in the prostate gland, which become metastatic and move traditionally through the lymphatic system and into the bones.
Okay, so it's kind of like not taking the garbage out, right? The cell stays in the body and it starts to get in the way of other organs. And it's like having the trash can overflow and, the next thing you know, you're keeping garbage in your refrigerator.
Exactly.
So, is a tumor cancer, or what's the difference between tumors and cancer itself?
Tumors are just a group of cells. You might think of any organ as a tumor. It's just a group of cells. The difference is that tumors don't have a function. Tumors are common in that most people have one or more types of tumors in their body. A tumor is just an abnormal growth of cells that serves no purpose. They can be liquid, like a pimple on your face when you're a teenager, or they can be solid. Tumors can be benign or metastatic. As we've said, metastatic means that cells travel through the body to other places. A benign tumor has cells that don't travel.
I hear that as far as metastatic cells go, many men have prostate cancer that never really affects them. Like they die and then they have an autopsy and the doctor realizes they had prostate cancer this whole time and it never changed the way they were living. So are there ways to judge how bad prostate cancer is, different levels?
Well, that's one of the big problems that medicine has right now, is that if you do a PSA on an older man, you may find that their PSA is elevated. And let's back up and say, what's a PSA test? It's a test that looks for a particular antigen that's made by prostate cells in the body. And there's a certain level that you have in your body because you have prostate cells. If those cells become irritated, for instance, if you ride a bicycle and put some pressure up in that area, you can irritate the prostate a little bit and your PSA will go up. So a PSA is not a perfect test by any means. It's a very inexpensive test, and it's just a marker that something's bugging the prostate cells or the prostate gland. So to answer your question, is there a way to look at how aggressive the prostate cancer is? Not exactly at this point. You have to paint a picture of what's happening in the area. So the first step would be a prostate a PSA test. Another test is to do what's called a digital rectal exam, where you actually feel the prostate to feel is it soft, does it have any lumps in it. Once you've done that, you have a sense that there's a lump in there, your PSA is high or elevated. That doesn't tell you that you have cancer. What it does tell you is that there's something that we need to watch a little closer. Traditionally, up to this point, that person would then get referred off. They'd have a biopsy done. If the biopsy showed any changes in the cells, then they would have surgery. And what we found is that that's just radically over-treating folks, because many of those things are never going to affect the person's life. So what many people now are beginning to say is, rather than rushing off to have a biopsy, let's look at what happens to that PSA. So you do serial testing. You test it over and over again. Is the PSA staying the same? Then there's probably not a need to do any further testing. Is the PSA elevating? How fast is it elevating? At what point do you refer off for a biopsy? If there's repeated tests and the tests are continuing to elevate, then would make sense to have a biopsy done. The biopsy is just simply poking a needle into the gland, taking a little bit of tissue out, and then looking at that tissue under a microscope. And the pathologist will give that tissue a grade. It's a subjective measure from 1 being completely normal cells to 5 being completely abnormal cells. When a cell is dividing quickly, its reproduction makes mistakes. Normally, cells divide at a certain rate, and they do it extremely well. So there's an exact copy of the cell. But when that starts happening really quickly, there's mistakes that get made. The faster it's reproducing, the more mistakes are made. And when you look at that cell under a microscope, what you see is that internal structure of this cell begins to degenerate. And the pathologist can give it a grade. So a grade of 5 would be the worst, very little architecture of the cell is remaining, 1 being normal. What the pathologist does is look at what's the most number of cells that have a particular structure. So are they all normal except a few, or are they all abnormal? And he gives the most cells in that tissue a grade. And then he looks at the second most number of cells that seem similar and gives that a grade, adds those two together, and forms a Gleason score. Gleason scores can range from 2 to 10, 2 being normal, 10 being abnormal. 6 and below is questionable, 7 is intermediate, 8 and above is aggressive.
So if I were to have one of these tests done and the pathologist looked and they saw that most of my cells were a grade 5, and then the second biggest group of cells were grade 3, that would be 5 plus 3 is a Gleason score of 8?
Correct.
Okay.
So an 8 could be a 4 plus 4. It could be a 3 plus 5. So you have to look at the numbers. There's other things that will give you an indication of the disease aggressiveness. Is the disease in both sides of the prostate? How much of the prostate's involved will sometimes tell you a little bit. The big thing is that you can't look at one particular study done at one time. That's a picture in time. Cancer is a growing disease, and so what we'd like to do is to try to get more of a moving picture, a movie if you could. Well, that's hard to do with the current studies that we have. The hard part is that in order to really be effective, we know if you treat cancer early, the earlier the treatment, the more effective it is. The problem is that in order to get a drug approved, you have to show that it increases lifespan. The easiest way to do that is to find someone who's nearly dead and give them a drug and see if they last a little longer. Well, then, when you can do that, the FDA says, wow, that's great. We're going to approve that drug in that environment, in the hormone refractory post-chemotherapy environment. Now, physicians can use drugs off-label, meaning that they can use it anytime they want, But these drugs are grossly expensive. One of the new drugs that I recently saw costs $100,000 a year. The insurance company says, we're not going to pay for it unless you're using it for what it's approved for.
Wow.
Which means that you have no access unless you're independently wealthy to these new drugs until just before you die. So there's some new drugs that came out that would be very effective for me at this point, but I can't get them because they're $5,000 a month.
Yeah, because you're not Bill Gates. So
right.
Initially, unless you're incredibly wealthy, the FDA will only approve this drug for you if they've seen it work before, and right now where they've seen most of these drugs work is in people that are nearly dead. So they're waiting for you to reach that condition before they actually give you that medication?
Well, it's not an FDA issue. The FDA does a really good job of saying, we don't want people to develop willy-nilly drugs and give them out because these are powerful drugs. They can do nasty things. And there's a long history of people who have rushed drugs to market that turned out to be very bad. Killed a lot of people. So they approve it. When you do a study, they say, yep, based on your study information, we agree that this drug is safe to use and effective in this environment. And then the physicians say, gosh, you know, if we know it works in this environment, we know it's going to work in this one, why don't we try it? The trouble is that they're super expensive. As I said, one drug that I looked at was $5,000 a month. The insurance company says, wait a second, that's an expensive drug, and we're not going to just give it out. We're going to give it out only when you're using it in what it's been approved for. So it's really an insurance issue of they don't want to pay for things that they deem are experimental, even if that can extend the life of someone.
Talk about, I heard something about people with a Gleason score of 6 or below not having a disease that should really be treated. What's that all about?
Well, again, when we talked about a Gleason score, we're looking at individual cells in a sample. And what we found is that 1 is a normal cell, so a Gleason score of 2 is absolutely normal. So you're looking at 3, 4, 5, and 6. Those are cells that have some structural changes, but aren't really, they look kind of normal. So the question becomes, are those cells going to be aggressive and change their architecture and go on to an aggressive prostate cancer, which will kill the person? Or are those cells going to stay relatively indolent, which is a term that really means lazy? They're not going to change much, and the person will end up living a long life and dying of whatever, not because they have prostate cancer. In fact, one study found that people 85 years old, there was a large percentage, maybe 80% of them had prostate cancer. But it was just this indolent form that wasn't going to kill anybody. So should you take all those people that you find, because we've done PSA testing now, we found that they have an elevated PSA, then they sent them off to biopsy, and they found that there is some architectural changes. They have a Gleason score. Should we send them in and do radical prostatectomies on all of them, which is going to leave the guy with impotence, his sex life is gone, and he's going to be incontinent, more than likely? Dramatic changes treating a cancer that would never cause him any problems. That's why the controversy. There's this gross overtreatment of these people. So what they found is that a Gleason level of 6 or less, if you watch it over time, it may be that it stays at a Gleason level or 6. It never goes anywhere. And so you can do what's called watchful waiting. Repeat studies looking to see if there's any changes. Gleason 7s, I said it was intermediate. Those folks may be a candidate for watchful waiting, but more intense watchful waiting. And we know that a Gleason 8 or above, those are pretty aggressive scores. So they would be more a candidate to immediately go in and treat. The idea that has come about by a group funded by the federal government that we shouldn't do PSA testing because there's all this overtreatment doesn't seem to make any sense to anybody. In the pre-PSA period, before there were PSA tests, men would just die. You wouldn't have no idea you had prostate cancer until it metastasized out, got into your bones, you developed bone pain. They would figure out that you had it. There wasn't really a lot of options, and you just died. They started doing PSA testing and found there was a 30% reduction in the number of people that died from the disease. I mean, we know PSA testing works. So how do you stack those two things up with this huge overtreatment of the disease versus testing finding a large reduction in mortality? And it's probably because we don't use serial testing. It's not that we test too much, it's we don't test enough. We do one test and send it off. The whole idea that everybody with a Gleason score of 3 or above needs to be treated is ludicrous.
Right. So is it possible that something with a Gleason score of 5 or 6 could become metastatic?
Absolutely.
Right.
Absolutely. I mean, there's some genetic change in those cells that have caused them to begin to reproduce, and that fast reproduction is causing mistakes, and so you see it as a pathologist with a change in the cell structure. We know that that's cancerous. And there's a potential that if not treated, and that's been the argument for years and years and years, we know you have cancer. We know that prostate cancer is the number 2 cause of cancer death in men behind lung cancer from smoking. So if we don't aggressively treat this, you're going to die. Unfortunately, there hasn't been a recognition that most of these cancers are Gleason 6 or below. Folks are saying now maybe is not even cancer. It's so indolent, lazy, it's not going to grow. It's just going to be there. So treating the other ones.
Right. But it's still a good idea to take these tests. I mean, these PSA tests are like, $50?
Yeah, they're not expensive. They're relatively inexpensive tests. And I don't think that you can make a blanket statement. That's the problem that we've had. We've tried to fit everybody into this little round hole of testing or not testing. We know that if you're found to have prostate cancer, aggressive prostate cancer, there's about a 10-year window of things that we can do to keep you alive with hormone drugs and radiation and all the things that we do. So if you don't have a 10-year lifespan, why would we want to aggressively treat this disease? Because you're probably not going to live the 10 years that we're going to gain you by treating it.
Right.
So if you're 60 but you're a medical age of 80, maybe you've got heart disease, you've got diabetes, you're just a wreck. Or that 80-year-old who just because he's 80, we're saying, no, we're not going to do that. Well, what if they're a really young 80? My father-in-law is 82. He hikes every week. He goes backpacking. I mean, he's probably 60 in biological age. So you can't really, it's a discussion between the physician, the primary care physician, and the patient. What do you want to do? If we're going to do a PSA test, we're going to open a can of worms. That can of worms says we could find that your PSA is elevated. That could lead you to a biopsy. That could lead you to other treatments. What's your lifespan like? You have 10 years. Well, if you're only going to live for 10 years, why even go down that road? If you're going to live for 20 years, I was diagnosed at 43. Well, 10-year lifespan to me wasn't really an exciting option. So I think all of those things have to be taken into perspective, and there are no black and white. That's why the recommendation from the preventative task force that says, well, we shouldn't do PSA testing is so aggravating and irritating because it takes a one-shot fits everybody approach. If they didn't start doing testing on me until I was 50, I wouldn't have made it till I was 50. I was diagnosed at 43 with an aggressive Gleason 7, which is pretty aggressive cancer. And even aggressively treating it, I'm still fighting it 10 years later. If I hadn't done anything, I'd have been dead by 50. So I believe that you should do more testing, serial testing over time. Draw a picture. Have the discussion with people. Look, reasonably at the person that you're talking to. Are you 90 years old? Do you want to live another 10 years? Maybe you don't. Why would we do the test? If you're 80 and you think, I'm going to live to be 120, absolutely, let's do it. And let's do it over time and figure out, is this an aggressive disease or a no big deal kind of disease?
Right. Is there anything, just kind of a last word you'd like to say to our listeners? Is there a word of advice you'd like to give to men with an elevated PSA level?
Yeah, a couple things. I believe that one of the major causes of the problem of how to treat prostate cancer, as I said, is that it's treated by surgeons. So if you're given a diagnosis of potentially a prostate cancer problem, get referred to an oncologist, a medical oncologist, and have him be the quarterback as opposed to a urologist. In a major academic center, the urologists, oncologists, radiation guys, they all work together. But in an outpatient, in a small community, even a small community like Spokane, those folks are very different and they don't talk to each other. So having a person who's not vested in a certain treatment program as your quarterback is probably a good choice. So I think that's the first thing. The other thing is that you have to remember that when you go see somebody, you're a patient in a long list of patients that person's going to see that day. When I walk in, I understand that in that person's eyes, I'm a prostate cancer patient. They're not looking at me as a person with goals, family, a history. I'm just a patient. And I have to force that person to see me as not just a patient. I'm not a prostate cancer patient. I'm a person that happens to have prostate cancer. The team that I have is an oncologist, an endocrinologist, a urologist, my primary care doctor. And those people, I need to make sure that they're all communicating with each other, which they don't. So I need to bring it to them and be able to discuss it with them, which means I have to understand it. That's the biggest thing. You have to be responsible for your own health care and not leave it up to the professionals.
Well, thank you for that advice, Mr. Parker. I hope all our listeners out there are taking notes. That's all the time we have for today. That was Rob Parker. I'm BJ Sinclair, and this is SPRA Radio.